These are in listen-only mode.
Good evening, everybody, and welcome to this evening's New South Wales COVID-19 update webinar. We are joined by our RACGP and New South Wales Ministry of Health panel members tonight, Charlotte, Penny, Kerry, Tanya, and Nigel. Thank you for joining us. Before we jump in, I would
at the
just like to
moment.
make
So,
a quick acknowledgement of country. We would like to
right.
recognise the traditional custodians of the land and sea on which we live and work, and pay our respects to elders past and present. So to start us off this evening, I'm going to hand over to Tanya, and she's going to take us over some of the clinical aspects that lots of people have been asking questions about. So over to you, Tanya, and thank you for joining us.
Look, thank you very much, Sammy, although I noticed Kerry has joined us, so I'm not sure whether Kerry would like to just make some introductory remarks before I do.
Look, it might be useful if I just give an update. I'm sure that my GP colleagues are aware of the sort of situation, but certainly we've seen a stabilising in cases. Currently, we're really trying to ramp up community testing, particularly in areas where we've identified cases of COVID transmission where there isn't any link, representing that there might be more widespread community transmission in those sites. We are probably going to see, with increased testing, potentially an increased numbers, but still trying to aim for those very low numbers as we try and flush out any community transmission. We are likely to be moving in probably a couple of weeks to more widespread testing across the state. We have got ample testing capabilities, particularly for our fixed platforms through New South Wales Health Pathology, complemented by the private pathology providers. But at the moment, we've got limited access to test kits that are more rapid turnaround, and that's likely to be a feature for a little while. We have been rolling out gene expert devices, which which is a PCR-based device that can go in smaller facilities, and the turnaround time for that's about an hour. But we're getting a limited supply of cartridges each week, and so we've placed those devices, or New South Wales Health Pathology has placed those devices in a number of rural regional areas, but they're really for high priority and they're low throughput devices. But that's a challenge. And I noted St Vincent's is working up another PCR-based test by a manufacturer called QIAGEN. But again, I believe that that's constrained supply. So bottom line, we've got ample testing capacity, but for your rural regional GPs, we're just conscious that it does take time to get it to the most mainstream labs. So whilst we are trying to mitigate that by having these gene experts that do the COVID testing, there is really a constraint on the number of those we can deploy due to the cartridge availability, which is still in short supply. So that probably just summarises where we are at and what our strategy going forward. And Tanya, did you want to add anything to that?
No, I don't think so, Kerry. I suppose everybody's aware of the rapid decline in the number of new cases. Whether you wanted to just perhaps amplify a little bit about the community spread, particularly, before I talk about some of the clinical things.
So I suppose the community spread is we're picking up people in the community, but what we're also uncovering is once we test those people, that we're often picking up wider distribution of cases linked to those, which is the importance for us increasing testing levels so we can uncover those sort of hidden clusters in the community. I really want to appreciate the GPs, particularly in that Waverley, Randwick area. They've just really ramped up testing and really assisted us in understanding and controlling and containing community transmission. But I think a feature of this, our approach going forward will be this very much working in partnership with GPs saying, look, this is a hot spot, we're seeing some cases here, let's do some ring fencing, high rates of testing, let's find out what the extent of community transmission. And pleasingly, in a number of areas when that's occurred, there hasn't been more broad spread community transmission. I should like to highlight that some facilities, particularly aged care facilities and other sort of institutional settings, are really challenging once we get COVID in there in terms of the amplification of the disease. and obviously in the case of aged care facilities, very vulnerable populations, and so they're going to have significant mortality. So I think that's going to be an ongoing challenge we have to face with GPs, is as COVID potentially enters the community. We know the disease is incredibly mild in many, and so it's going to, and potentially in some very, very minimal to asymptomatic, level. It's going to be a real challenge us keeping it out of aged care facilities, even with a lot of controls in place.
So just to pick up a little bit on some of the clinical features, you're probably becoming quite familiar with most of them yourselves. There's still debate around the extent of spread between asymptomatic individuals. The window period that we're thinking pre-symptomatically that spread might occur within is of the order of 1 to 2 days. But the rate at which spread is occurring still suggests to me that people are not at their most highly infectious in that pre-symptomatic period. The issue that's also coming up, and has been the case for some time, is when patients are truly non-infectious. And you will be aware, I'm sure, of some of the criteria for a patient who's had infection to try and indicate that they can come out of isolation. They're clinical criteria, but there are also 2 negative PCR-based tests. We have been seeing some patients who actually have quite prolonged positive PCRs. Normally they become negative within a week or so. What we are not so certain of, though, is if the PCR remains positive for a prolonged time, is the patient actually infectious? So that's still information that we need to glean with an increased number of cases. The symptomatology, you're probably aware that there's been discussion in addition to the classic presentations of anosmia being noted in a number of patients. So it's important to think of that because it's not an insignificant percentage. And it seems like the changes in taste are as much related to the anosmia as they are to primarily changes in taste. The other thing which is becoming evident, and perhaps more the case for inpatients, are that there are some additional clinical tests that may belie an important set of abnormalities, and in particular in relation to myocarditis that's associated with a proportion of patients with COVID. And in those cases where it occurs, it's likely to cause arrhythmias and to be associated with a significantly elevated troponin. So that's one of the risk factors we're actually quite interested in now testing routinely for in patients who are admitted to hospital. And quite clearly, since we know that some of the chronic disease associated risk factors along like hypertension and cardiovascular disease in general influence mortality, partly in association with age, I think the troponin story is one that we need to just be highlighting.
Thank you. That sounds. Yeah, can we ask you about the test, the false negative, false positive of the test results? There's been a few questions coming up around that, and there's also that issue of potential reinfection where people have swabbed negative and or seem to be waxing and waning just below the PCR positive. Could you comment on that?
So the issue of false positive and false negatives, there are different estimates coming from different parts of the world. As far as the PCR on respiratory samples and upper respiratory samples is concerned, some countries have said it might be as high as 20%. I think that's rather high. I think there are a number of issues that can influence that. Excuse me, one of which is in relation to the adequacy of the sample. In order to do a PCR, you have to actually have sufficient cells that are infected with virus in the sample. We're not actually looking at virus that's extracellular here. So it has to be a reasonable sample to start with. The next issue is that, yes, there is a false negative rate. And yes, if you're suspecting the disease, you should repeat the test. The point to make about a negative test is, does that mean a patient is not infectious as opposed to your failure to make the diagnosis? One issue we're also very interested in the hospital setting when patients are symptomatic is to try and correlate what we might call the viral load as measured by PCR compared with infectivity as judged by culture of the virus. And that's where there are some ongoing studies.
And I guess that also asks the question about, self-collection and whether self-collection is a valid thing to be doing.
Look, I think if people are appropriately taught how to do it, it's certainly helpful, and in the context of large numbers of patients potentially in a community, it's a way of achieving samples without putting other individuals at risk, for want of a better way of saying it. But one of the things we've been quite interested in at Westmead is actually doing a bit of a test around if we have someone observing people in our clinic taking these samples by themselves in comparison with a trained observer having taken them, is there really a difference? We haven't actually got the answer. So the short answer to your question is yes, taking or self-swabbing, particularly parents with children, I think might be an appropriate thing to do, but they do need to be told how to do it properly to get the appropriate sample.
And I think,
Thanks,
Charlotte,
Tanya. Well, yes, I mean, I've read some data coming out of Melbourne showing that they've done a similar look at the sort of the specificity and sensitivity of self-collection versus the lab. So they did them before the pathology lab person collected them, and they've actually found that they were as good as the path lab, which to me then says that it does answer the question that a lot of GPs have had, in particularly in rural remote locations, where it's been quite difficult to persuade patients to go an hour's drive to where there's been an appropriate pathology collector to take the samples, and so there may have been a lower number of patients actually accessing testing than should have otherwise happened. That maybe we should be sending out a message to our rural as well as city colleagues that that is actually the way to go, rather than us fussing about them finding a centre where a potentially infected person is being asked to drive a long way, get tested and then go home again, which really, you know, seems a bit bizarre when we're trying to get people to stay as close to home as possible anyway.
There's absolutely no reason why, if they know how to take it properly, they're going to get a different answer from you or I trying to take it. So I completely concur with your suggestion.
The issue, I guess, is the discomfort in taking it too, isn't it? That has to be managed.
Well, it's uncomfortable whoever takes it, isn't it, Penny? So we just have to do that. But I think in terms of just trying to...
Sorry, the mums just have to be a little tough on the kids, that's all.
Can I then just go down that kids one? Because again, I saw some other data that came out that was saying that there's been very little evidence of children being the transmitter of illness to adults, whereas it is the other way around, that adults can transmit to children. Children don't tend to be terribly sick, but they don't seem to be transmitting it to the adults in any way at all. Have you seen those figures, and can you comment?
Yes, and I think Kerry might have some data actually from New South Wales that's very relevant to this question. But there's certainly the evidence we have is that kids do not seem to be transmitting infection to adults. And that would really fit with the evidence that we have that they're not transmitting particularly much between each other. And Kerry, perhaps you would be in a position to talk about some of the school-related data which would speak to this question.
Yes, certainly. I was just looking at my emails as well. So just to let Dr. Christine McCartney, who is the head of the National Centre for Immunisation Research, has been working on in partnership with us to look at the transmission that may be occurring in the setting of childcare settings or in educational settings. And what they've done is done both PCR testing and then also done some serology in a number of different schools. And in summary, this will be published and put out, and we're obviously engaging with our colleagues in education because it's material to policy considerations, which is the fundamental driver of why we initiated this research, is that the children do not seem to be amplifiers of the disease. So if the children are acquiring it, they tend to be acquiring it from adults, but what we know is that the social interactions between staff or the staff-to-staff transmission is the predominant feature. It's not to say that there's no transmission amongst the children, but clearly it's not the major feature, it's more the adults, which goes with, I suppose, Tanya, the thinking that the children are getting maybe milder illness for whatever reason, having a much milder viral load, a lower viral load. Did you want to comment on what the sort of underlying physiology or premises that might be for that?
Yes, so I can give some data and then speculate. I think might be the best way to say that. Clearly, children are making up still a relatively small percentage of our overall caseload, and the kids at primary school and in daycare an even smaller percentage. So the percentage in the under 20s is low, but it's even lower. Like I think it's around 2% or thereabouts, although I could stand corrected on that figure, and maybe we can check up on that while I'm speaking.
Well, I think it's 1% in the 0 to 9s and 3% in the 10 to 19s.
So clearly it's very low. Now, why are children asymptomatic largely or have very few symptoms, and why are they not transmitting infection? Logically, they must have relatively low viral loads because the ability to transmit infection is related to the amount of virus present and being coughed out in the secretions. I guess if they don't have symptoms and they have low viral loads, that is to say they're not really coughing, then the opportunity for transmitting the infection is reduced, but that wouldn't necessarily get away from the infected secretions being left on surfaces. So it's clearly not the entire explanation. One thing that's been exercising my mind, and it's completely speculative, is whether or not kids have a different number of the actual receptors in their respiratory tract that the virus needs to bind to, so that they don't get such a level of infection that you see in adults where the virus has to bind to specific receptors on the epithelial cells within the respiratory tract before the infection actually develops. The only other explanation, apart from, you know, the exposure, low virus load and that type of host thing, is really there's something special about children's immune systems, but I find that a little bit hard to believe. Nevertheless, some of our colleagues are very interested in comparing the immune response in children with that in adults. So it'll be very interesting to actually understand that when the data come out.
And Kerry or Nigel, maybe this is a question for Nigel, but just can you talk a little bit about the rationale about sending children back to school and how that will pan out over the next few months and what the thinking is there?
So I'll take that one. Nigel's just stepped out, but it's probably within the bailiwick of the sort of discussions that are happening about the way forward. So the Australian Health Protection Principle Committee has always supported children being at school. That's probably based on a few different issues. One is that we've been fairly confident that children have mild disease. That's probably, I think we've seen enough of the disease in other parts of the world internationally. Clearly our data again sort of shows that it's not a major issue in that age group. And so that gives us some comfort. And also, we also noted that there weren't really outbreaks reported in children in schools, which is often a feature of other diseases. So a lot of the modelling data and some of the work that's been done to underpin it draws on flu. And we know that, for instance, influenza, the younger children, the under 5s, particularly the under 2s and under 1s, are most significantly impacted by influenza. And we also see that children are more likely to spread influenza because they don't control their respiratory secretions. They're a bit grotty. And that's a different picture than we're seeing for COVID. So some of the work that people have done in terms of the arguments around children's contribution to spread has been, I think, drawn from some analogies about influenza, because it's a respiratory pathogen that's been well studied in that sort of setting. So AHPCC has considered the fact that we haven't got outbreaks, disease is quite mild, and then, as I said, we early on recognised the importance of generating this evidence around our children contributing to the spread, or how children are getting infected. And at the time we started this study, there was a belief, and the World Health Organization had said that they think the predominant way kids were getting infected was by the adults. And I think, I don't want to oversell, there's still work, Christine's still in the field exploring and analysing further data, but certainly the preliminary information available is not suggesting the children are the major source of spread, and it really is about controlling the health of the adults that they're interacting with. Now, there's always going to be exceptions to that rule, but that's clearly the thinking of the AHPCC after reviewing the evidence. The other considerations are that schools are really important. As a public health physician, I know that schools are incredibly important environments, safe environments, environments where children acquire important social skills, and for many, a place of important structure and learning. And so for that reason, and I know again, the importance of education for children in terms of longer term outcomes. So for all of those reasons, I think the evidence doesn't justify us maintaining school closures, and that's why I think you've seen quite strident support for schools being open. As long as we can address those issues that are really concerns of parents about making the school environment as safe as possible and protecting teachers. So I think we have to get over that hurdle of putting in place a range of strategies. So how schools look in term 2, the Premier has indicated she will be announcing that shortly, but that's sort of the health advice is really resuming schools on balance is the right sort of setting we need. And also we're thinking that this is not a short-term issue for us in dealing with COVID. I know we've been talking about COVID for a long time, but we're going to be talking about COVID for a very long time. Very long time. A very, very long time. It's going to be 12 months to 18 months to, we may be talking about this in 2 years' time. And so I think we've got to think about what is the settings that we need as a society to get through it over that very protracted period. It's not to say that in response to community outbreaks or response to other things that we wouldn't actually close schools as a sort of public health measure to dampen down movements at that time. But I suppose that summarises our current thinking in relation to the evidence about schools. I don't know if you want to say anything, Tanya?
Yes, one of the things that was being highlighted in various electronic media this morning was the issue which parents need to think about, because if the kids go back to school and they're actually dropped off at school by their parents, the parents need to remember that they still have to social distance and not, congregate outside the school or go off in large groups for coffee simply because the kids are back at school. And I think that might be a message, Kerry, that needs to be promulgated to some extent. The other thing is, the kids want to go back. My grandkids really want to go back to school. They just hate being at home confined all the time. So apart from the educational value, as you pointed out, Kerry, I think the social value is really important.
And
I'm
also,
sure there's a lot of parents that would agree.
Yeah, so and I work a lot in disasters, and in a general, as a general sort of, I guess, comment, one of the things we know that's most important after scary events or big events is to have a routine for children and have them able to maintain that routine. And so we know after bushfires, for example, one of the first things we want to do is get the school up and going again, and that brings a routine to the children and that brings a routine to the family. And so I think that's also a really important thing going forward, because that sort of mental health of kids and family is really important. So one of the questions I know Charlotte and I both want to ask you, Kerry, is around the influenza vaccinations. So we've been having a bit of a mixed rollout of the influenza vaccination. So there are practices that are receiving it before others, and then there's practices running out and not able to get the supply quickly enough. And I guess what the question would be around how it's being distributed and how we can improve it so that practices have access to it when it's needed.
Okay, so I actually looked at this issue today, not even thinking about this webinar for another reason. And just to let you know that we didn't put any restrictions on the orders. You know, we had actually talked to you about the fact that you were likely to do mass vaccinations or some options of bringing all your well people together. So we didn't do that, and I'm pleased to say that we have rolled out all of the vaccines. So by tomorrow, we will have completed all of the vaccines for that first rollout. Anyone who put their orders in has actually got their first orders. What I think we're encountering is the fact that there's been incredible demand, and we've distributed vaccines faster than we've ever done in any other year. We'll put up the graphs on the charts. We've pushed them out, but we need to work with you because we're now into the replenishment of the round 2 reordering from the GPs, and the stock is obviously in high demand. So we will push out the next second round orders, but everyone who put in an order for the first round, and as I said, for the first round there was no limitation on the quantity, you actually have got that. We'll have that by tomorrow. And then we're now moving on to people with repeat orders, and we'll push those out as quickly as we can. I think one of the challenges for us is the private market for vaccine. And so the NIP vaccine, we have got a large volume, but I think we're going to be really pushing the limits with that. I think we're going to have incredibly high uptake if the feedback we're getting already is in place. But I think what's going to be challenging for GPs is the private supply and the fact that there's sometimes no discrimination in patients. They just want the vaccine, whether they've got to pay for it or it's in the NIP. And I do get a sense that there's maybe an unequal supply of the private market vaccines supply. So we are going to work with places like the Pharmacy Guild and others just to better help patients navigate where they can pick the vaccine up from to bring it to the doctors if the doctors don't have a private vaccine in their fridges. But we really have to open to any other suggestions. But I think for us, the private supply is going to be probably the most challenging. We also have not pushed, probably, again, trying to pick up on the lessons learned from previous years. I haven't gone out there saying, go forth and get your flu vaccine, and I'm going to hold off with grim death till next week to even say that. So that will give us a bit more time for vaccine to be out there. But, you know, I just want to let you know that we've been committed to rolling it out as quickly as we can. Yeah.
Fantastic. And one of the messages I'd love to see get out there personally is the fact that the over 65s do need to go to their GP to get it, because we are having a number of over 65s thinking they're getting the adjuvant vaccine, but are actually getting the private vaccine. So, Charlotte, did you want to comment on that?
Maybe I could comment there to say that these issues have been raised with me, and we're, I think, got a meeting scheduled with the RACGP, the Pharmacy Guild and the Pharmacy Society, just to make sure that we've got all of the correct messages and correct settings in place for this flu vaccine season.
Yeah, thanks, Kerry. And the other one message that I've put out to everybody who's listening as well is remember to value add and do the pneumococcal vaccination for all your 65s and overs who haven't had their vaccine yet, and any who are immunocompromised who actually qualify to have a pneumococcal vaccine. Because similarly to influenza, if they did get COVID, it's really important that they have the vaccine in place already for pneumococcus.
Can I just also suggest, which you probably do already, is that individuals having pneumovax to put it into their non-dominant arm. I had it recently, and I can assure you I was very glad it was in my left arm.
No, well, I always say dominant arm, and I always warn them that it gives them far worse a sore arm than the flu shot does. But which is why it's good to do it at the same time, so you can only complain once. But can we move from vaccinations? Is that okay with everybody? I'm interested. There's a few questions coming through talking about testing again. One is I want to just raise the issue about the antibody testing, because I know I'm certainly very keen on discouraging GPs to do any antibody testing. So I'd like to just touch on that with you and your opinion on that. And the other one is, what is the actual rate of false negatives for the PCR? We sort of talked about there is false negatives. What is actually the rate? And then finally, there's a question around the throat saliva for PCR testing, which is apparently being done in Hong Kong, and what that looks like from the Australian perspective.
So
okay,
first,
so go. Or you can go with antibody test if you want.
and you can fill in what I've left out. So the serology or antibody test does not diagnose acute disease. It takes time for antibodies to be generated in response to infection. It varies a little bit with the kind of antibody test, but it's of the order of 7 to 10 days. Maybe in the future we'll have some that are positive a little bit sooner, that seroconversion occurs. So the purpose of the serology is, yes, you can take a baseline test, but it wouldn't be expected to be of value to test it for 2 weeks. So obviously in terms of making an acute diagnosis, it's not particularly helpful. Where it is helpful is in tracking the spread of disease, and maybe Kerry can talk about that a little bit more just in a moment. If I go to the false negative of the PCR, I can't give you a definitive answer in Australia. As I said before, reports from overseas have said that it might be as high as 20%, but that's a single test. We don't know how good the actual swabbing technique was for that particular set of reports. And I think the answer is, if you think that it could still be COVID, then you should repeat the test. There was a third component to your question, I think.
Throat saliva.
Oh, yeah. So that Hong Kong study was really interesting, because that was coming out at a time that was suggesting that saliva is as good as nose and throat swabs for detecting virus. We were all interested in that in Australia, of course, because the supply of swabs and various other things is obvious. Well, really the testing equipment was in relatively short supply, and obviously if a patient, in the same way, if they take their own swab, if they can produce their own saliva without you having to be there, that's another convenience element of it. When one of my colleagues who has friends in Hong Kong asked them about the technique of obtaining saliva, I guess to put it nicely, it's a posterior throat saliva specimen. There's some particular way that the Hong Kong Chinese spit, which involves a sort of back of the throat production of saliva. In other words, it's got some respiratory secretions and cells with it, rather than just spitting it out of your mouth. So if you're actually going to recommend that, then people need to be aware they've got to try and cough it out from the back of their throat. We've been doing a study trying to compare that, but we don't have enough samples at the moment to actually give you the answer. They're also trying to do that in Melbourne, I think, so hopefully we'll have a little bit more information shortly. Kerry, did you want to follow up on the serology?
Yeah, look, I also wanted to say that innovation is wonderful, but innovation has to be within parameters of sensitivity and specificity. So there are obviously a lot of antibody companies that have potentially not had a long track record in antibody testing, but coming forward with antibody tests, and each of those need to be validated and test for sensitivity and specificity. So even then, even though there are some antibody test kits, even though the caveats we've got with that Tanya's mentioning around the delayed and they're not useful in acute, some of the test kits performance data I've seen is actually indicating that some of them wouldn't really be ever useful in terms of their sensitivity and specificity. In terms of the seroprevalent, but we need to monitor in each test kit, we need to evaluate, and that may be useful for us in some components in the future around the antibody testing. So we're open to that, but just being clear that there are a lot of test kits that potentially are not very reliable that are antibody test, notwithstanding the limitations Tanya said. In terms of seroprevalence studies, we're actually commencing a seroprevalence study. So that's being led by Christine McCartney, John Caldor, and it's part of a research consortium that Tanya's been heavily involved in terms of leading, because we've recognised that we do need to understand how we're going and charting ourselves through this. So the first components of that are going to be pregnant women, opportunistic samples that have been taken in private pathology and public pathology. And we're doing that under both ethics, but also the Public Health Act ability we've got to do that. And we're also looking at potentially doing that in school settings or other settings to actually make sure we're reaching some groups in the population, particularly children, that we think at this time may be underrepresented in some of those opportunistic ways we collect serum. So that will be important in mapping our way through this to actually understand seroprevalence. And I think this is critically important. And I think, Tanya, just to reflect, this is probably another interesting dimension, is I think we've only had very few seroprevalence surveys done internationally. A lot of the data on determining the prevalence of infected has been modelled prevalence. I think there's been some recent studies either coming out of Germany in one of the towns that were infected, which showed that even though it was hit quite hard, only 15% of the population had antibodies. So I think these seroprevalence surveys across the world will be really useful in us mapping the way the virus moves through the population, so that we can actually adjust our models, because modelling is only modelling, and this will really help us do that. I don't know if you had any other comments on that, Tanya.
Yeah, I think it's really interesting that there seem to be pockets is too small a word, but there seem to be some suburbs, for example, or some areas where there are higher rates of infection than others that are not fully explained by the demographics. Like it's not a suburb where there's only elderly people, although in Mosman, I guess there are a relatively high proportion of elderly people, but there are also a high proportion of travellers. But anyway, we can look across New South Wales or Australia in general, and for some reason, some suburbs are more affected than others. We don't fully have that explanation. And that's really why some of these serological surveys are very important. I think the other thing to note is that Australia is actually relatively unique in its ability to do sero-surveys, which it's been doing through the National Centre for Immunisation Research and Surveillance, of which Christine McCartney, who Kerry referred to, is head, for vaccine preventable diseases of various sorts for many years. And so they've established some very good networks for obtaining some of these residual serum samples from laboratories, but also from the blood bank, so that we can get a picture of what's happening in the community.
Fantastic. Thank you, Tanya. Nigel, I wanted to ask you a little bit about, we're talking about at the moment we've got physical distancing going on, a lot of that going on, and there's talk about the curve coming down again. I'm just wondering what the I guess the strategies are for moving forward from now, and what the rationale is behind that in terms of health system strategy.
Yeah, I think there's two components to it. First is going to be about what happens in relation to the decisions from the public health side of things, which AHPPC are considering, and Kerry probably can talk about some of those. And then there's going to be the response that we have in relation to the health service response in terms of what things we will start to do again in providing care, because we're very conscious at the moment that we've got a lot of our hospitals actually and our clinicians under-occupied, because we responded quite quickly to start to say we needed to make capacity available for COVID patients. And while we've been really successful with the public health response, we're not seeing that demand flowing through, and so we've now got a lot of capacity in our system we need to turn back on. So I might let Kerry talk about the strategy in the population health side of things, and then I'll come back to the service side.
And I suppose to say that there is not a clear path through. There are lots of things that we've learned about the virus. There's lots of knowns. We're lucky that we're relatively early compared to some of the international countries, so we can actually learn from those natural experiments that are occurring overseas. Again, what's worked well and what's not worked well. So ultimately we need to have immunity, a significant proportion of the population immune, whether that's vaccine derived or a significant proportion of the population that have acquired immunity through infection. How we move through that and the settings we take are complex. So there's probably been some discussion about whether it's possible to virtually eliminate this virus in Australia, given we are an island. And that's challenging because of its very mild nature, its potentially pre-symptomatic transmission, and a lot of unknowns. You know, how can we possibly seek it out? Potentially with some constraints in testing capabilities. I mean, more for having the rapid testing and the mixed testing that would be ideal. Notwithstanding, I think we've got pretty robust testing capacity compared to the rest of, you know, a lot of other countries internationally. Then there's the, you know, do we try suppressing it? Do we try keeping it down really, really low?
Isn't that the New Zealand strategy?
No, New Zealand's more elimination, I suspect.
Okay, so they are full elimination and containment.
Yeah, full elimination, lockdown, try and eliminate. And then there's the model of where you go down a suppressed road, you know, where you're trying to really keep it low. And can I just say, one person's elimination could be one person's really low suppression. You know, some of these are not, there is a sort of like, if I say it as 3 paths, I'm going to describe 3 paths, but there are interconnecting ring roads across all of these paths. So suppression would be where we're really trying to keep the numbers down really, really low. We recognise that elimination isn't there, but every time we have community transmission, we've got high rates of testing, we're jumping on it, we're doing the public health contact tracing, we've got some level of social distancing, we're maintaining quite a lot of structure, but we've potentially got some, you know, some more economic activity going on, but we're suppressing it at a really low, reasonably low level. And then there's the component of more, I suppose, the Swedish model, the controlled transmission sort of model. I'm not sure that that's going that well for Sweden at the moment, but too early to tell. But that's where you almost just try and protect the vulnerable and let it spread through the community with some mild mitigation, but not comprehensive mitigation or intention to really suppress it to low levels. In the end, though, we need to have, if you're following path 1 or path 2, you're doing that because you, at the end of this, you want to very much hope for better capabilities. So you know, some of those strategies could be reasonable to buy time, and that's what we've actually done, to actually buy time so that our hospital system is better prepared. We've got ventilators, we've got PPE, we've got testing capacity, we've got public health contact tracing, we've got apps or technology that can really assist us through this. So it's almost like being prepared. Have you got all the tools that you need to before you would actually try and calibrate any response? But ultimately, we need either really effective treatments that drop the, you know, that are so effective, or we need, so that it could be a mild disease for the vast majority of people, or a vaccine that's going to give us immunity, and hopefully one that lasts a more than annual, you know, a long-lasting vaccine, or a good vaccine that is pretty effective across all age groups. including the elderly, who are going to remain very vulnerable to this disease. So I suppose they're the sort of paths we might choose, but how do we go and how we negotiate there? They're really complex questions, and I think Australia's in a great position because we can actually look at some of the countries that are probably months ahead of us in where we are. There's salient lessons from looking at those countries, but it's a good position to be in, to be able to reflect, learn, and get our system ready. And I suppose that's what's been our focus of activity, and Nigel's really conscious of Nigel's work in preparing our clinical community, looking at the ICU and some of that system preparedness. So
I think the overwhelmingly successful response from our public health side of things and the decisions government have made on their advice have certainly led us to the point where we wanted to be, which is not in a situation where we're overwhelmed, where we actually are able to care for people who need our treatment, who can access ICU, and where we get the best possible chance for people to survive the disease. So that's a great thing for us, and I think we're all very pleased that we're actually in this place. It's really interesting, though, that our clinical communities are still not confident about where we're at, because they've seen what's happened in China, Italy, Spain, UK, US, and they believe we're still on the same path. And one of the things that I think will be important for us as we move through is, no matter what happens with the changes in the decisions around the public health measures, that we continue to build the confidence of our clinicians that we are not going to be overwhelmed, that it is going to be different here in Australia and in the New South Wales context. And that's building, but I have to say our clinicians still have a lot of mistrust. They still get concerned that there's a fair bit of undiagnosed COVID circulating in the community that is going to come and hit them. And we're constantly messaging about the work that's being done on the public health side, the extent of the testing, the rates of positives that are being seen, the fact we're now being much more liberal in who's being tested to test the prevalence in the community. So I think those things will need to continue on. And what we're also now talking about with our clinicians is, what do we start doing again, which were stopped? There were a lot of decisions made quite precipitously because we felt we were going to have a crisis. And now that we are being a little bit more, able to manage this more carefully and thoughtfully, we need to start to recalibrate the system to bring back things that are really important to continue to do from the point of view of maintaining the health of our citizens, particularly things like screening programs, managing chronic disease. We'll need to think about what we start to do in the outpatient settings that have been turned off. A lot of things in oncology that were slowed or stopped. There are a whole range of things now that I think we need to reassess given where we're at, but we need to get the clinicians confident, because at the moment the big issue is PPE. They don't want to start doing it as they feel completely safe in all of the activities that they do, and we still are limited in our PPE. That's probably the major constraint issue that will limit us in thinking about what we start to do more of.
And can I say that's exactly the issue for the GPs, and that's their biggest concern, is that until they actually feel confident that they have adequate PPE, opening up anything more or being asked to do more is actually fairly scary for them in terms of what that looks like and how they do it. So I acknowledge that we've made the hospitals we've allowed the hospitals to have capacity, etc. But now we need to actually have the front line have that same sort of feeling of safety in being able to then open up what we do. And that will then also make the patients feel safer, because I've certainly seen the figures already about the numbers of patients dying from, heart attacks, etc., because they haven't actually even presented for care, because of probably their own fears about being infected with COVID-19, or that the system can't cope with them, when we all know that in fact the system is absolutely able to cope with them.
Yeah.
I think these are really important issues as we navigate it, because we want to make sure that people feel safe in our hospitals, and I think it's important. And look, we're not out of the woods yet. I mean, this is a very tricky virus where we see if it's got the right circumstances, it can be amplified really easily and spread. And so we do need to make sure that, particularly in institutional settings, particularly have incredibly low thresholds for testing. You know, we will be, you know, we really are trying to be quite liberal with the testing. We think by sort of naming hotspot suburbs where there's community transmission, it actually increases or motivates people to sort of go out in those suburbs. But really want to work with you at really increasing testing, because that will give us a really good handle, and we're better off to find those cases as early as possible, because what we're demonstrating is often chain, you know, when we uncover one, we find a chain of transmission when we do that contact tracing. So we really want to work with you to increase testing.
Cool. I've got two issues if I can. One is just confirming that at this point in time, a patient who is 10 days post-diagnosis, having had no symptoms for 72 hours, they don't require the 2 negative PCR testing that they previously did.
The exception to that would be anyone who works or is going back to a vulnerable healthcare setting. So
okay, so a healthcare worker or anybody else needs to
worker, disability worker, someone who was going back to a vulnerable setting. We want an additional level of assurance for those ones.
Okay, so I'll just clarify, for somebody who's just sort of basically in a normal workplace and mostly working from home at the moment, we say that they are able to go out and maybe get their groceries for themselves once they've hit the 10 days, and that they must have had 72 hours of no symptoms for no testing. But anybody who's actually potentially going to put anybody who's vulnerable at risk needs to have the negative test to confirm.
Yeah.
So that next one brings me into that vulnerable population, because we know that there's been an aged care facility where there has been a carer who had mild symptoms and was working, and we've now potentially got that situation to deal with. That sort of raises an issue, because I know that there's been a lot of concern about, you know, carers going into aged people's homes and looking after them, and do you say they shouldn't have anybody coming into their home, or what should we do? My biggest concern is that we should not be putting aged people at risk of not having appropriate care. So do you have some sort of advice to help us in terms of that? And then too about the PPE that maybe the vulnerable people should be accessing regularly, those sorts of advice around people coming in and out of homes.
I'd probably say a couple of things is we've got a message that, you know, why COVID is so tricky is because it can be very, very mild and in some people. And so just really messaging, and this goes for you as well, have a really low threshold for testing anyone in any things. You know, the minimal symptoms, just test. You know, that's one of my messages, and just tell, don't go to work. I think the issue for us is we're going to have a discussion about the right balances that protects the elderly but also makes them have good care, and that socially and emotionally supports them. So I think that's going to be a debate we are going to have with the community, with elderly people, with the Superannuation Society and all the advocates, because I think we're also at the moment seeing, and I know, Charlotte, we've discussed this, you know, concerns around end-of-life care in aged care facilities, the importance for elderly who may well balance the risk of COVID against acquisition of COVID versus, you know, seeing their grandchildren and interacting, because that may in fact give them greater joy, and they're pragmatic about this. So I think this is a time where we actually have to start engaging with those that are most vulnerable to sort of optimise this protection versus quality of life. And I think GPs are so well positioned to really do that. And I think also having very clear the work around the wishes of people, particularly those with significant chronic diseases and the elderly, about their end of life care, and making that very simple. These are probably good practices that we would normally put in place, but I think they're the importance of them are really amplified with COVID-19.
Yeah, I think that's a really big issue going forward. Look, we're actually coming up to 8 o'clock. I don't know, Sammy, did you have any questions that you wanted to ask from what you've been seeing coming through?
Look, a lot of them have been fielded. There is still a lot of questions coming through around how we can confirm when someone is cleared of the virus, saying that there's people still testing positive, but there's no symptoms, or what do you do when someone has, what do you consider symptoms? Because someone might still have a mild cough for several weeks following infection, and just a lot of questions and uncertainty from that perspective are coming through.
What I might suggest we might do, Charlotte, is just to, because this is something we're learning about as well, when we're finding that you can actually detect the virus for quite a long time.
Which is the South Korean experience too. We didn't really touch on that sort of thing about whether, yep, anyway, sorry.
So the issue is whether the virus is actually live or infectious, and all of these factors. What I'd suggest we do is maybe pull together some information that we can circulate around, which sort of reflects what we know, what we don't know, but obviously having a very cautious approach to anyone who's working in a setting that puts them in contact with a lot of vulnerable people or in a lot of other people. And, you know, it may be in some circumstances we have to seek expert advice. So let us pull together some more comprehensive information. But clearly we're grappling with this as well. I don't know, Tanya, if you wanted to say anything, but it's an issue for us as well, because we do find that some people have prolonged detections of the virus. Tanya?
It's one of the key questions at the moment, and we've certainly had a couple of patients for some weeks have been positive. And in a sense, it's hard to imagine, since they're not very symptomatic or asymptomatic, that they are still infectious. But that's the group I was talking about earlier, where we're trying to follow up with viral culture as well as PCR, because the viral culture at least confirms for us that the virus is alive, whereas the PCR doesn't necessarily do that. After all, we're just detecting part of the genetic complement of the virus. But
so that'd be
sure,
great if we could have some sort of, at least some figures, and that might cover off to this sort of South Korean story of where it looks to me like it's more likely that these are people who've still got evidence of the virus present, whether or not it's infectious or not, rather than them being reinfected, which sounds like there's very little evidence for that.
Yeah, and Charlotte, I think that's an important factor, and Tanya, you might want to comment, but when I've had this conversation with Christine McCartney, I mean, I think the sense is that, of course, we can't rule out reinfection, but we wouldn't think that happens in a very short period of time, given our normal knowledge of the way the immune system works in response to viral infections. But Tanya, did you want to talk about that?
No, I think that's absolutely right. And if we wanted to be confident about reinfection in terms of looking at the virus itself, the only way we can determine that is if the virus has changed to some extent, so that in whole genome sequencing, we can actually see that the patient's infection is caused by a virus which has genetic differences from the original one. And we're not at that point at the moment. We're early on in the epidemic, although it seems we've been talking about it for a long time, but it's really very few months, and the virus has not evolved to any great extent. So proof of concept, if I could use that terminology, we don't have logic, and previous experience with any viral infection, as Kerry said, is that you do develop immunity. Unless you have a problem with your immune system, then the majority of patients will be immune, and If you have a PCR that is positive and then becomes negative and positive again, we have actually seen that. And that sometimes occurred in patients who've actually gone on to develop a lower respiratory infection, in other words, pneumonitis. And it's one thing that I actually forgot to mention when I was talking about the clinical course, is that during the second week, patients can worsen, and that seems to occur concurrently with the host inflammatory response coming up. And some of the patients that actually end up severely ill or in intensive care, it's more in relation to the ARDS type syndrome, in other words, the host response, rather than the actual virus itself. So a rather long-winded answer to a fairly straightforward question. But I think I would agree with Kerry that the evidence we have from other diseases and what we have to date from this virus is that we don't believe reinfection is a significant issue. That's not to say it never occurs. It might occur when you're immunocompromised, for example, but it's uncommon.
Thank you.
So thanks, Tanya. I think on that note, we might hand over to Sammy.
Yes, thanks, Penny. That does bring us to just after 8 o'clock, so we will wrap up for this evening. I would just once again like to say a big thank you to our panel members, Charlotte, Penny, Kerry, Tanya and Nigel, and also to everybody that joined us online. As always, we've had far more questions than we've been able to get back to in the 1 hour period, but just to reassure you all again that we do look into them further offline and do our best to address them in future sessions. So in saying that, I'll let you all get back to your evening, and we'll be in touch in the coming days to let you know when the next COVID update will be. Thank you and good night, everybody.
Good night. Thank you.
Good night. Sammy, how many people were online?
Almost 600
500.
this evening.
Wow, that's good. Thank you. Thanks very much.
I was going to say, and Kerry and Tanya, there's been a number of appreciative comments here about congratulations to New South Wales Health and the entire team, and thank you to Kerry and for managing the and putting in all the effort to manage this pandemic so well. So there's been quite a bit of positive feedback coming through, which has been very nice.
Yeah, we just I just want them to test. Don't worry.